Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me one of the leading figures in CLL world today, Dr. Nitin Jain from MD Anderson Cancer Center. And we're going to discuss data from the AMPLIFY study as presented at the American Society of Hematology meeting in December of 2024. Welcome, Nitin.
Thanks a lot. Excited to be here, and thanks for the kind welcome to this meeting.
Thank you very much. It's a pleasure to host you. So, before we get into the trial, the Amplify study, could you tell us what the lay of the land is today in terms of frontline treatment for CLL?
Yeah, so right now we have, I would say, three consecutive indefinite treatment for CLL: ibrutinib, acalabrutinib, or zanubrutinib. These are the colon BTK inhibitors which you can give continuously, daily, forever. And we also have a time-limited approach of venetoclax plus obinutuzumab, which is given for a 1-year duration. And outside of the United States, we also have approval of venetoclax plus ibrutinib of 1-year duration, 2 oral drugs together. But right up until now, we don't have an approval in the US of 2 oral drugs together. As I mentioned, ibrutinib plus venetoclax is approved ex-United States. So Amplify study was basically coming into the same arena, basically arguing or investigating 2 oral doublets, basically 2 oral pills, acalabrutinib plus venetoclax, as you kind of shown the slide here. But they also added a triplet of acalaven obinutuzumab. So really the three kind of the best drugs we have out there. And their control was historical control, to say, not historical control, but chemoimmunotherapy, which certainly has fallen out of favor these days. But this was, I guess, was considered appropriate when the study was designed. So it's a 3-arm study. Chemotherapy as a control arm, 290 patients. Acalaven for 1-year duration, 291 patients. And then the triplet of adding obinutuzumab as well, 286 patients. And the primary endpoint of the study was the progression-free survival, which was actually powered for AV, the doublet, versus chemoimmunotherapy. But then they had many subsequent secondary endpoints, which are kind of listed in the slide as well.
So, what was the demographic of the population accrued?
Right. So, as you can see the slide, so this was a younger patient population, as you would expect, slightly younger than typical CLL patient you would see in clinic, largely because the control arm is chemotherapy. So you have to have patients who can tolerate immunotherapy well. So the median age here is 61 years, which again is typical for many of these studies. Most of these patients were enrolled in Europe. About 17% were enrolled in North America. And if you look at the right side, so one important aspect is that because this is a chemotherapy control arm study, patients with deletion 17p or TP3 mutations were excluded because you don't want to randomize those patients to chemotherapy. So we don't have that patients in this mix. But patients had unmutated IGHV about 57 to 59%, as you can see here in the table. And complex karyotype, which is in the poor prognostic marker, was about 15 to 60%. Overall, pretreatment characteristics are very typical of what frontline younger patient with CLL you would treat in practice.
So, what was the top line data like?
Yeah, so this was the data sets which, was presented at ASH, and then that's the reason it made it in New England Journal. So the primary endpoint was progression-free survival, and the primary endpoint was progression-free survival of AV, the doublet of AV, versus chemoimmunotherapy. And the AV here was 76.5% versus 66.5% for chemotherapy, and this was statistically significant with a hazard ratio of 0.65. Notably, the AVO, the triplet arm, was actually numerically was higher. The PFS at 3 years was 83%, and if you compare it with chemoimmunotherapy, the hazard ratio was 0.42%. So certainly both the doublet of acalaven and the triplet of acalaven obin were outperforming chemotherapy for progression-free survival. And this was the primary endpoint of the study. So we are kind of expecting this regimen, both AV and AVO, to be expected officially by the FDA soon. Though I should mention that the NCCN guidelines back in February of this year have already added these regimens to the NCCN guidelines. So potentially you could prescribe it to your patients, and hopefully insurance will cover it because it's already on the NCCN guideline.
So, what did the subgroup analysis show?
Yeah, so anything important context in the field of CLL is to, kind of see these different genomic subgroups and how they have performed. But basically, the most of the benefit of the PFS benefit, I would say, or especially so with the FCR, unmutated patients, we know they don't do very well with chemoimmunotherapy. And that was also seen. The median PFS was 43 months here. And both the AV and the AVO actually did very well in terms of for the unmutated patients. For mutated patients in general, uh, all patients do well. Chemoimmunotherapy also did well. So if you look at specifically the mutated IGHV patient, there was no statistical difference for the median PFS between the three arms. But having said that, given the long-term complications with chemoimmunotherapy, we do not recommend using chemoimmunotherapy for any patient with CLL. And similarly, I think for patients who achieve MRD remission or undetectable MRD remission by flow cytometry. So this is among the patients who achieve that, those patients tend to do much better with even among those patients, it looks like AV, AVO were outperforming chemoimmunotherapy, even if if they were to achieve MRD negative remission.
And I understand that this trial was done in the COVID era and may have had some impact on the outcomes.
Yeah, so this trial I think started in 2018 or 19 timeframe, something like that, and certainly it overlapped with the COVID era. And as you may recall, during the COVID time, especially 2020, 2021, there was a lot of discussion about using CD20 antibody because there were other studies which had looked at that, and that increased the risk of deaths with COVID infection. So not a surprise here that similar to that data set, when you use obinutuzumab in AVO or rituximab in FCR and BR, there were more COVID deaths associated with it. So 21 deaths in the FCR BR, 25 deaths in the AVO, and 10 deaths in AV. So, but there were proportionally more deaths in the rituximab and obinutuzumab arm, and that really affected the PFS and the OS curve because if you were to exclude those deaths, now you can argue whether that's the right thing or not, but the investigators did report PFS and OS outcomes censored for COVID deaths. Certainly the AVO curve will even reach higher because you're excluding the deaths from COVID, which professionally occurred in the AVO arm.
So, in terms of survival, what do we know so far?
Right. So, as we were just talking about, so if you look at the survival overall, the AV performed the best because, those COVID deaths were not really seen as much in the AV arm compared to the other two arms. If you were to censor for the COVID deaths, which is the figure on the right side, practically all the arms were doing very, very well. So I think, but still they were the both AV and AVO were outperforming chemoimmunotherapy. So I think overall, I mean, I think the regimens this really makes a further point that we should not use chemoimmunotherapy over patients, but really rely on target therapies.
And I understand, obviously, one of the attractions of any Ven-based regimen is the depth obtained. So, what can you tell us about depths of response?
Yeah, so MRD is becoming a key important endpoint, which kind of be an earlier endpoint of intermediate, you can say, endpoint to long-term progression-free survival, as has been done in myeloma and many other settings. So kind of a similar theme is emerging in many of the CLL studies. And this trial also reported MRD in the peripheral blood by flow cytometry. Now, if you look at in this table, which is shown, if you look at the top part, and if you look at the UMRD at end of treatment, which is the second row from the top, the AVO was 67%, which is where you would expect it to be. And FCR chemotherapy was 45%, but somewhat surprisingly and unexpectedly, with the AV doublet of AV, the MRD rates were actually not as high. They were about 34%. Now, similar trials which have been done with ibrutinib plus venetoclax, these numbers are in the 55 to 60% range. So it was a bit unexpected that the MRD rates with the AV were on the lower side. Having said that, despite MRD being on the lower side, the actual PFS, which we just talked about, was actually quite impressive. So that remains to be kind of ascertained, or why that happened, why AV does not have this much higher MRD as we were hoping for. But that, I guess we'll have to see what happens with longer follow-up.
And what can you tell us about the tolerability and safety of these regimens?
So I think one important aspect when you talk about AV, AVO, and FCR, and is that the side effects were calculated or counted for the duration of the actual active treatment, because AV and AVO were given for 14 months of duration. Chemotherapy was given for 6 months, so there is some difference in kind of the actual ascertainment of side effect profile. But I think if you go to maybe the next slide, which talks in more detail about the specific side effects which are seen with these agents. And I think the important thing is the neutropenia, which is listed on the top. If you look at the grade 3 or 4 neutropenia, which is ANC of less than 1, it was seen in about 27% of AV, 35% of AVO, and then about 32% with chemoimmunotherapy. So obviously we know that with chemoimmunotherapy. So I think it's important to recognize when we're using these doublets and triplets, the grade 3 or 4 neutropenia can occur in quite a few patients, and we should be prepared to kind of manage that. Also, if you look at the febrile neutropenia, which is towards the bottom of the slide, which are obviously very important to see, much more with FCR and BR, 2.5% with AVO, and 1.7% with the AV. So that again something to watch for. Hopefully, I think most of these febrile neutropenia didn't lead to any significant, didn't lead to death or anything. But again, these patients should be monitored closely for treatment of that.
And obviously, the BTK inhibitors are themselves associated with certain side effects. And so, how did that pan out in this trial?
Yeah, so I think most important, people want to look at atrial fibrillation risk, which is listed on the slide here. And because it is the time-limited approach, patients just finish treatment in about 1 year. It's not like a long-term BTK. So we don't see as much side effects, let's say atrial fibrillation, as you would expect with 5 or 6 years of therapy with a BTK inhibitor. Notably, they also looked at ventricular arrhythmias, which was quite low. Most of these were ventricular extrasystole. And an overall infection rate, grade 3 or 4 infection was numerically higher in AVO, but again, most of these were COVID infections, which led to that high rate of infection risk. So overall, I think not a surprise in terms of the toxicity pattern, similar to many of the other studies with doublets and triplets have reported.
So, what are your key takeaways from this study?
Right. So I think the trial met the primary endpoint, which was the progression-free survival superiority for Acalabrutinib doublet versus chemoimmunotherapy. Also, the triplet also outperformed chemoimmunotherapy. So I think the trial met the objective it was kind of assessed for. And as I said, we are expecting an FDA approval of this regimen hopefully soon. Also, the overall survival was in favor compared to chemoimmunotherapy, making another point that we should not use chemoimmunotherapy for our patients. And overall, I think the side effect profile was similar to what you would expect with these doublets and triplets, because many other doublets and triplets have been reported previously in different settings for frontline CLL patients, so nothing unexpected toxicities to say. So overall, I think we all are expecting this to become a major regimen, which will be used for patients with CLL in the United States and elsewhere.
So, before we wrap up, a couple of questions. One, before the era of three drug regimens in CLL, how did you think through what two-drug option to give your patient? And now that you have three drugs at least already on the NCCN, how has your practice changed?
Yeah, so I think this is an evolving kind of concept. So right now, I think what I would say is that, first of all, we are really moving away from long-term BTK therapy, like taking a Acalabrutinib for 5-10 years or Zanubrutinib for 5-10 years or longer. I think that may still be appropriate in some sense for patients who are deletion 17p or p53 mutation, because that's a group of patients which were not studied in this trial. And that's a group of patients where I think still most people would think of a continuous BTK as the standard approach outside of a clinical trial setting. Also, for patients who are older and frail, if you have 85% in your practice, you probably are not going to subject them to a triplet regimen, just maybe too toxic at that age group and logistically more challenging, and maybe just easier to give a second generation BTK inhibitor and have a kind of a long-term disease control. But for a large majority of the patients who are in the younger age group, patient in their 60s, early 70s, many of them are looking for time-limited approaches. They don't want to be on a treatment for the rest of their life. And in that, right now, the only available regimen is Obinutuzumab for 1 year. But as I said, we will soon have Venetoclax for 1 year, two oral drugs, which makes the logistically much more easier to treat patients. And also the triplet regimen. But I think I would say that moving forward, at least in my practice and outside of a clinical trial, I would start using more of IGHV mutation status as one of the drivers of decision making. If I have a patient who is young, who is IGHV mutated, these patients do very well with Obinutuzumab, but also cross-trial comparison, they're doing very well with Acala plus Venetoclax. And Acala plus Venetoclax, the two drugs, two oral pills, will make, I think, logistically things much easier to give. For the unmutated V gene patients, the best outcomes, at least in cross-trial comparison, we are seeing with the triplet, with Acala and Obin. Now, you could argue that that would certainly lead to more toxicities, and is that worth the risk or worth the toxicities? And whether should I still use the doublet or just do Obinutuzumab doublet? And if a patient were to relapse down the line, I can still salvage them by using the same therapy again, or pirtobrutinib, or degraders, or whatnot. So, given that we have multiple regimens available for CLL which are working very well, yes, you can optimize your PFS1, and if that's the issue, then yes, triplet may be better. But you can say, okay, I'm going to use just doublet, preserve my other drugs for later use. And overall, I think long-term, PFS2, PFS3, to say, I think with all these regimens will turn out to be relatively equal in my opinion. So I think in some sense we have so many good drugs that I think any of those combinations may at the end of the day will probably reach you at the same time point that the patient will do well long term.
So would you be comfortable giving any P53 deleted or mutated patient a finite duration treatment?
So yeah, that's a fantastic question. So there is data, limited data right now for time-limited approaches. So there is a study from Germany where they treated 45 patients with Ibrutinib Obinutuzumab triplet, where it worked well, but then there were patients who were relapsing once the treatment was stopped. Matt Davids from Dana-Farber has a Acala Obin triplet where he treated 45 patients with the triplet, and their 4-year PFS is about 70%, 70. So I think you can achieve long-term remission. But again, we don't have really large data sets looking at truly time-limited approach, because many of these studies who are time-limited also have this MRD-directed component, like, oh, if you're MRD positive at 1 year, you can do 2 years. Or if you're MRD positive at 2 years, you can do 3 years. And so it's maybe not truly time-limited. So I think the jury is out there, in my opinion. I would certainly enroll patients on clinical trials which are investigating that. Outside of a clinical trial, as long as you know what you're doing, if you want to use a time-limited approach, and if the patient were to relapse on the line, you can certainly salvage them. I think it will be appropriate to do. But I think in general, the recommendation would be to use a continuous daily therapy as of now.
My last question is regarding MRD then. Where do you use MRD today in your frontline treatment? Is it something you're using for decision making?
Yeah, it's also a kind of a evolving topic, and I think certainly as part of clinical trials, it's been done routinely to generate medical data. Outside of a clinical trial, I use it in the sense of prognosticating patients or telling the patients what to kind of expect. For example, if I'm using a time-limited approach in the frontline setting and the patient is MRD positive at the end of treatment, and I stop treatment, I know that this patient is going to relapse sooner than if that patient had no MRD or undetectable MRD. So that for sure is well established in the field and makes intuitive sense. What is not well established right now is what to do if they are MRD positive. Should I continue treatment longer? Should I add another agent? And that some of the data we have generated and others have generated seem to suggest that some treatments could be extended longer and you can achieve MRD negative remissions with longer treatment. But I do think that there are some important phase 3 studies which are being done right now. For example, the MAGIC study, which is being done right now, which where you get Acalaven for 1 year, but then based on MRD, you can do more Acalaven. So I think some of those trials, which are really using MRD to make treatment decisions, when they get reported, would help further. But I think right now my role is more my assessment. Though I'm using MRD, but I guess I would say the data is somewhat limited, and not many people in the community certainly are using MRD to make treatment decisions.
And your MRD, is it flow based? Is it NGS based? And yeah.
Yeah, so historically it has been flow cytometry based, which we still do. I would say in the last couple of years, we're also starting NGS MRD assay just because we're using for acute leukemia patients with ALL. And so we have also started to use MRD, NGS MRD for our patients with CLL as well. But I think most of the decision time points I would say are based on a 10 to the power minus 4 cutoff, which is the more traditional cutoff with flow cytometry. Either you're checking by flow or by NGS, but using 10 to the power minus 4 as a decision tool.
And that is on blood?
That is on blood. I mean, we have done both blood and bone marrow, but I think just practically for CLL patients, I think blood should suffice.
Well, I want to thank you very much for spending the time to educate our audience about how the field is evolving. And obviously, you've got a ringside seat, and you are among the key people who produce the evidence that everybody then looks to for their own decision making. So it's a privilege to have had you on the program, and I hope I can reach out to you in the future again.
Sure, absolutely. Delighted to be here.
Thank you.